PSMA PET imaging of the prostate. أستاذة الدكتورة رشا صلاح، أستاذ الأشعة التشخيصية طب عين شمس.
Good morning, dear professors and colleagues. It's my pleasure to be here today with you. We were going to discuss PSMA PET imaging of the prostate. This is my acknowledgement where I performed most of the cases. We will talk about introduction about the PSMA PET imaging, the hint about the technique, and we will demonstrate some of our cases. Let's start what do guidelines say regarding PSMA PET. Is it indicated or not indicated? Recently, the PSMA PET imaging is indicated by the European Association Urology, starting from the biochemical recurrence. Only in the patients with biochemical recurrence, they recommended to perform PSMA PET imaging. While the NCCN guidelines started from 2022 in estimating the PSMA value as regard the initial staging for prostate cancer, especially for the patients with unfavorable intermediate risk and high risk or very high risk patients. So PSMA is now implemented in the guidelines either in initial staging as the NCCN guidelines or in biochemical recurrence as the European Urological Association. So what is the PET imaging? First, we injected the patient with the radioactive material, which is the PSMA, and then we wait for 60 minutes, and then the patient go to the imaging CT or PET MRI machine. Initially, the staging for the prostate cancer in intermediate or high-risk patients included CT or MRI or bone scan for proper giving the patient staging process, while they have some limitations regarding detection of the accuracy of the metastatic deposits, regarding particularly small retroperitoneal lymph nodes and also the small volume bone metastases, which could be missed by bone scan. Let's see this example. This patient has prostate cancer and he has elevated PSA. And this is the CT imaging performed for this patient, showing this small lymph node at the retroperitoneum. Just a moment. This small lymph node over here. On the CT image alone, we can say that this lymph node is non-specific and it could be just a reactionary lymph node. While when performing the PSMA PET image, it showed a significant increased uptake, and this was proved to be malignant lymph node. So the PSMA changed the diagnostic staging for this patient to have a distant metastatic para-aortic lymph node. Let's see this another example with patient with prostate cancer and high Gleason score 4+4, and it was performing the bone scan, which appeared to be completely negative with no significant bone metastasis. While on looking on the CT performed for abdominal staging, again we can't see any pathology in the osseous structures in the lumbar vertebrae. While after performing the PSMA, there is a significant PSMA uptake located at one of the vertebrae, and this upstage this patient to have metastatic bone disease. The impact of gallium PSMA is established and studied by this systematic review performed in 2018, and it included a very large number of patients, including more than 1,000 patients, and they included more than 15 studies, and they discovered that the PSMA PET-CT changed the diagnostic process of the patient and changed the staging of the patient, and accordingly the management was completely changed according to the new staging for these patients. Another study comparing the bone metastasis regarding PSMA PET-CT and bone scan, and this study again discovered that the PSMA is more reliable than bone scan for detecting bone metastasis. And this was an example from this paper, and showing the bone scan, which is completely negative, while the PSMA showing widespread osseous metastasis. Nowadays, there is a new era in the PSMA imaging, which is the PET MRI, and it is again studied by a systematic and review meta-analysis established in 2020, and it also included multiple studies, and they included more than 2,000 patients, and it shows that the PSMA PET MRI have higher sensitivity regarding the initial diagnosis by about 94% for evaluation of the prostate cancer, and also it is very helpful in restaging of the prostate cancer, and it is very important in the restaging process. So when to ask for PET-CT and PET MRI? Let's see the difference between both. First, the agreement between two studies was high. It ranges from 71 to 95%, and PET MRI is slightly superior compared to the PET-CT regarding the prostatic lesion, in particular location of the tumor and the local extension of the tumor, accordingly due to the higher resolution of the MRI component compared to the CT component for local staging of the prostate cancer. Also, MRI is having such importance regarding the detection of small lymph nodes, because the evaluation of the lymph nodes may be small and it could be missed on the CT, while in MRI, PET MRI, the time for the exam is slightly longer, and it allows the tracer to be more accumulated in smaller lymph nodes. So PET MRI can detect smaller lymph nodes. Also, the PET MRI is helpful in evaluation of marrow lesions, which could be not visualized on the CT images, because the superiority of the MRI component detecting small marrow metastases. The PET MRI for the prostate, including state-of-the-art multi-parametric MRI for local staging of the prostate, and we also implement the state-of-the-art PET for the whole body for proper staging. And these are multiple literature demonstrating the value of PET MRI in different patient scenarios, mainly for the intermediate and high-risk patients, and also in biochemical recurrence. The PET MRI and PET-CT have nearly the same preparation. The patient should be fasting for about 2 to 6 hours before the exam. The kidney function test is important because we could need injecting IV contrast injection, either in CT or MRI, and we ask the patient to evacuate the bladder immediately before the exam to allow the patient to be comfortable on the table during the exam time. The multi-parametric MRI performed for the prostate, including the T2 weighted image and also the functional image, including the DWI and the DCE. Let's see the value of PET imaging in detection and staging. The MRI is superior, as we mentioned earlier, in evaluation of prostatic capsular invasion and seminal vesicle invasion. And also, both studies can confirm the nodal metastasis and the detection of small lymph nodes, even in non-regional lymph nodes. Also, it can search for uncommon metastases in uncommon locations, either by CT or MRI. They have nearly similar value. Let's see this from the literature. This patient has prostate cancer, and it was surgically removed, and then the patient came again with biochemical recurrence, and this was unfortunately brain metastasis located here, and it shows a significant PSMA uptake over here, with also a small recurrence at the operative bed over here. This is another example for a patient with liver metastasis, although it is not common for the prostate to have hepatic metastasis, but this patient has this hepatic metastasis. Let's see from our cases, this patient was presented with a newly diagnosed prostate cancer with the Gleason score 4+3, and he has a very high PSA level. This is the fused PET imaging showing a significant increased uptake at the peripheral zone of the prostate of both lobes, more on the left. And these are small metastatic pelvic lymph nodes that could be easily missed if we are doing the routine CT staging process. And unfortunately, there is uncommon site of metastasis noted also in this patient with this small obturator lymph node located over here, and it is not common to search in this lymph node group for metastatic disease, but it was proved to be metastatic disease. And this is the fused image showing the whole metastatic process. Let's move to another patient with recently diagnosed prostate cancer and coming for proper staging. This patient performing the PET MRI study. We can see here that there is a diffuse infiltrative mass infiltrating the prostate with a sizable extraprostatic component, infiltration of the seminal vesicle, as we can see on the MRI component. This is the fused image for invasion of the seminal vesicle, the extraprostatic component, the pelvic nodal metastasis. All these metastatic disease can be easily seen on the MRI alone without the PET image. However, the PET MRI added value that there is a small abdominal lymph node which could be missed on routine MRI evaluation. Another finding in this patient was this uptake which was located at the left ureter, and this is could be considered as normal physiologic excretion of the tracer on this PET image. While again, when we look to the conventional T2 image, we see that there is abnormal thickening at the left ureter near the vesicular-ureteric junction. And unfortunately, this patient was proved to have a double primary with left ureteric TCC and also advanced prostatic cancer, and it was pathologically proved. This patient have this huge prostatic infiltrative lesion by this MRI study infiltrating the seminal vesicle, and these are the nodal metastases. This was just a multiparametric MRI. With the multiparametric MRI, we discovered this small bony metastatic suspicious osseous lesion, and we asked for PSMA evaluation. This is the T1 weighted image showing this osseous lesion at the left pubic bone. And this is the post-contrast image showing enhancement in this osseous lesion. Again, when the patient performed the PSMA PET-CT study, the prostate showing a significant increased uptake more at the right lobe, and there is a small faint uptake located at the suspicious osseous lesion. And unfortunately, this osseous lesion is hard to be seen on the CT. Comparing the CT with the PET image, we can't see anything on the CT component alone, although it was very easily seen on the PET MRI, on the MRI alone. So when we combine the data of both studies, we confirmed that this is a true osseous metastasis, and it is only within the marrow, so it can't be seen on the CT because it didn't form any lytic or sclerotic changes yet. Another example for the value of the PET in this patient, here we can see a huge infiltrative prostatic mass with the PET imaging showing diffuse increased uptake, and this is the fused image confirming the diffuse infiltrative mass lesion. And this is the rest of the study, including the ADC and the perfusion image confirming the presence of sizable mass. But there are multiple lymph nodes located in this patient, as we can see here. This is lymph nodes located on the left side with other lymph nodes on the right side. Unfortunately, the lymph nodes, they didn't show any uptake. So they are completely different from the signature of the primary tumor. Are they metastatic lymph nodes? Depending on the MRI, they are large and they are showing some morphological change. So we can say that these are reactionary lymph nodes. When we depend on the MRI alone for staging of this patient, we can say that these are metastatic lymph nodes. But again, when we combine both images, the lymph nodes showing no uptake or the para-aortic lymph nodes show no uptake, even the mediastinal lymph nodes show no uptake. And this is the MEP imaging showing no uptake except for the prostatic lesion. And unfortunately, this patient, we didn't get the results of the pathology for him, and we considered that these are not metastatic lymph nodes from the prostate cancer. This is generalized lymphadenopathy due to other cause, maybe sarcoidosis or other. So we consider it non-metastatic prostatic cancer because of the complete different signature of the uptake of the tracer regarding the primary tumor and the lymph nodes. I will move to this case with the patient with the post-treatment evaluation after local treatment for prostate cancer using the HIFU. This is the T2 weighted image showing showing cystic change at the site of the previously treated lesion with no corresponding restricted diffusion, and the ADC confirmed that there is no restricted diffusion. And also this was confirmed on the dynamic study with no uptake at all. But also this was confirmed on the PET that there is no local uptake while the patient has biochemical recurrence. When we look again, we see this small lymph node and it is equivocal on the conventional image, but when we confuse the image with the PET image, they are showing increased uptake with other suspicious larger pelvic lymph node, and the recurrence for this patient was not at the primary site of the tumor, but he had metastatic disease. To sum up the cases, the value of PET imaging in prostate cancer is for initial staging. Regarding the local staging, MRI is more superior compared to the CT regarding extraprostatic invasion and the seminal vesicle invasion, and also evaluation of the urinary bladder invasion. While regarding the metastasis, we can do any of both studies regarding the PET-CT or PET-MRI for proper staging for nodal and distant metastasis. And the PSMA is also helpful in evaluation of treatment response and in biochemical recurrence, and this is more informative in MRI compared to CT component. Thank you.
Thank you, Dr. Rasha, for your presentation. I think PET plasma changed the landscape of cancer prostate in all situations, by clinician, by radiology, by surgery. And I think PET plasma added muchly to define the patient with normal imaging, CT and bone scan, with elevated PSA.
Yes.
Those patients are very important to do a PET plasma. My comment on your elegant lecture, that you have do PET plasma at initial presentation, because if you did it after treatment, you can see that the patient may progress.
You will be biased, yes.
Yes, so the value of PET plasma should be in the presence of initial PET plasma.
Yes, this is the recommendation of the NCCN guidelines in initial
many
staging.
patients do PET plasma in front of, not in the start, in between treatments. And maybe tricky because it's denoting that they have patient more mets. But the value of PET plasma is to do it pre-treatment and post-treatment. Another issue that we are dependently mostly on PET plasma on delineation, because we have a Stampede trial. It's a large trial in the oncology field. They enrolled more than 9,000 patients to receive chemotherapy and hormonal treatment before treatment for the patient with advanced prostate cancer. And they advise that oligometastatic patients should receive SPRT, stereotactic body radiotherapy, or local treatment for their bone mets. And the PET plasma added value for those patients because it is tailoring the nodal selection for radiotherapy or for local treatment by surgery, even the patient with metastatic setting with less than 3 number of lymph nodes. That's why PET plasma is fine-tuning our practice in cancer prostate, and also selecting our radiotherapy to the hidden sites, maybe the cause of PSA failure. Thank you, Dr. Rasha.
Thank you. Thank you.
It's an honor to me to present my dear colleague, Professor